Today we're talking about family histories. And so for many of you, you know your family history. There might be one or two of you here who's adopted, and of course that poses its own challenges in doing this. But we're trying to think about family history and what information we can get from family history as we think about precision medicine. And the argument I would make is that family history is probably our most cost-effective tool, at least for people who aren't adopted, who know their family history, our most cost-effective tool to be able to think about how to at least start the conversation with precision medicine. And so as we're thinking about this, we always get the patient history, that's fine, and the family history from the point of view of those of us who are considered geneticists and genomicists. We like to think about this about getting 3 generations of family history, and so very oftentimes the genetic counselors, I have to admit, are the best of all of us in terms of taking this information. It's the proband, their generation, usually the generation above them, and ideally the generation above them, and sometimes if they have children, the generation below. As we're doing this, lots of times, and I think many of you will appreciate this if you're clinicians, you start this process with a patient, and this may be an iterative process. That is that you ask someone for something, and they just may not know their extended family history. They may not be so medically savvy about this, and so you may get a lot of sort of question marks as you're going through this process. And in some cases, I have to say this is just a sociological commentary. I find that women know family histories better than men. I think women even know their husband's family history sometimes better than the men do. I don't know, we just seem to talk more to each other about these things. But anyway, so part of the trick in this is also who the informant is for you in terms of who's giving you the information. And I have to admit that I actually make a judgment in terms of the informant, in terms of how reliable I think that information is, either based on whether or not they're really connected with their family, if there was a divorce in the family, for instance, or someone's estranged, lots of times for good reasons, they don't know that. And oftentimes I'll find within a family there's someone who's kind of the medical ringleader. So oftentimes it is someone who's medically trained, a nurse, a doctor, a genetic counselor, or scientist sometimes. But oftentimes, whether I do this correctly or not, I oftentimes just wonder whether or not that information might be more reliable as we're going through this. And as I said, at least for us that do this for a living, a lot of what we do is actually resolve these ambiguities. So try and come up with more definitive information that we're getting from this family history as we're going through the process. So here's, I'm going to put a charge out to you guys. And one of you guys that raised your hands in terms of being the IT person, I am so praying that you figured out how to do this, okay? So this is your challenge. So if you think about what we do in terms of gathering this information, in terms of family history, we could ask Kelly, but my guess is the average family history that you take, even if you're doing it very superficially, probably is a 20-minute process. Would you say? Okay, 20 minutes, and if it really gets complicated, this can be even up to 2 hours in terms of being able to do this. So for those of you who are clinicians, the problem is for most of our face-to-face time with patients, we may have 15 minutes total in terms of being able to do that. And so the question or the challenge is, how can we get what's a very cost-effective tool in terms of healthcare, but how can you do that in a very efficient, accurate process without essentially wasting, if you will, the face-to-face time that you've got with your patient? And that's the charge. That's the task I want you to figure out, help us figure out how to do. So as we're doing this, I and others have thought about creative ways of being able to do this, and I do think it takes some creativity in thinking about this. As I related, one informant within the family is not necessarily ideal, and we actually know this based on studies we have of families. We actually get better and more robust information the more people in the family sort of, it's like crowdsourcing, right? But it's crowdsourcing within your family to be able to get the family history. Different people are connected in different ways. I know my cousin better than my brother knows my cousin, so I know a little bit more about her details. I'm a physician, so I know a little bit more about the specifics of my aunt's DCIS, and to know that it was DCIS and not really invasive breast cancer, so little things like that. Okay. So one question is, can we figure out a way to be able to crowdsource this, so use this as a family? The downside, or the potential way that, and again, I'm looking to the IT folks to be smart about this, how do you do this in a way that appropriately protects patient privacy? So there may be things, for instance, that maybe I want to contribute to the pool of data. Maybe, though, I don't like all my family members equally. Maybe I don't want to share everything with everyone. Maybe there's some deep, dark secret about, psychiatric disease in the families that they don't want to share. Understandable in terms of some of this. Maybe they don't want to share about their STDs within the family, but maybe on the other hand, about a cancer history, and something they felt like other family members could benefit from that might be hereditary, maybe that is something they want to share. So part of that is trying to figure out how can we do that, how can we crowdsource it, but do it in a way that's, you know, respectful of our families in terms of the information they want to give us. And then importantly, this is not a static process, hopefully. Hopefully your family isn't all dead. You know, hopefully you've still got living family members, and if that's true, then this can change over time. It can evolve. And again, it doesn't take a huge amount of time to update a family history, but the way we visualize it and the way we're interacting with the patients, sometimes it takes a little while to figure out, okay, well, Aunt Susie just died of breast cancer. Okay, now who was Aunt Susie? Was that on your mom's side or your dad's side? Was it your fourth or your fifth aunt within this? You know, figuring that out can sometimes be difficult. So as we're doing this, and I'm a very visual person, I'll tell you, and in part I'm a visual person because, as I'll show you, I look at the family history and the pedigree for pattern recognition. I'm just very quickly, in like 30 seconds, I can look in a pedigree if it's color-coded correctly, and I can tell you my hypothesis about both the risk that I think someone's at as well as the mode of inheritance. And the reason I say this is because the way a family might input this data and the way I might want to visualize and look at it may be different. You may, in terms of an efficient way of doing that, you may do it differently. Okay, so within this, now again, I'm looking for the IT folks. In an ideal world, I don't want you just to collect this data. I actually want you to do a calculation on the backside. So I want you to be able, if you can, to be able to look at this, to look at the size of the family, know what my denominator is essentially, knowing at age of onset of certain diseases, knowing at degrees of relationship between my family members, if it's a first-degree relative, a second-degree relative, a third-degree relative, factor all that into it, and if you can, actually on the backside, do some sort of risk calculator for me. If you can do that, you have just won the lottery in terms of being able to do, you know, the newest module in EPIC. Because that's what we really need in terms of primary care providers being able to very efficiently go through and do this. The challenge is, from my point of view, that you have to do this really across all diseases. So many of us, for instance, if I'm in my cancer clinic, I can tell you my cancer genetic counselors are absolutely fabulous. They're taking a family history that's focused on cancer almost exclusively. They're ignoring things, for instance, in terms of cardiovascular disease, metabolic disease. On the other hand, when I go in and I wear my other hat and I'm walking into my diabetes clinic, again, we're focused, trying to do this very efficiently. Lots of times we're taking information mostly about diabetes or obesity or hypertriglyceridemia. So the real challenge is, how do you do this and now do this really across all health and across all disease? So to be able to make sure that all of the doctors, and especially the primary care doctors, can most efficiently use all of this information. Now the upside is, if you could do it as a health enterprise for all of us in the faculty practice organization, that could be done once and it could be done system-wide. It could be an enterprise solution, so every time I go to each different doctor and each different specialist, we don't all have to reinvent the wheel and collect this information. We essentially get one solution to this whole entire problem, right? Okay, so does anyone know of such a product? Because I'm ready to buy it if you have. Okay, so that's the challenge. That's what we'd like to be able to do if we could. Okay, so here are some examples of what's currently out there to be able to do something like this, and I encourage any of you that, and again, the slides are going to be posted, so you can always grab these off the web once they are available. The first iteration of this was something that our government came up with. So the Surgeon General's office actually came up with this family health tool, and the URL is down here. So the recommendation was that for families, when they're around the Thanksgiving dinner table, to be able to actually share with each other, not just, you know, the wonderful things about the newest baby born in the family, but share their history of gout and their, you know, their problems they were having with hypercholesterolemia as they're eating lots of pumpkin pie and, you know, stuffing. But to be able to go through and do this, and the nice thing, this is simplistic, I will admit. It's not bad, but it's relatively simplistic. But the nice thing is you can put in information and it'll generate something that does look like one of these pedigrees. So for me, who's someone who's very visually oriented, it's nice that you're able to do that. Another one of these things from an ideal point of view, and again, think of EHRs in doing this, is what you'd ideally like to be able to do is something that you can enter this as a family, you can aggregate this work as a family, and you can immediately import it into an EHR. So whatever, and I don't speak this language, but whatever we have to do in terms of compatibility, it's something that just transfers over. I can be frank, this does something where you'll actually get a pedigree and you can print it out and you can take it into your provider. Okay, nice, but then I have the problem that I've got a printed pedigree, I'm scanning into an EHR, and I've just lost all of my ability to mine or get any data out of that because it's basically invisible to me as I'm looking through the EHR electronically. So this is a nice first step, but it's only getting us part of the way there. Okay, so I don't have time, and I'm not advertising, I don't have stock in any of these things, but I'm just putting these up as examples, and it's something that for those of you that are interested, definitely take some time and play around with these this weekend or something. So some of you will like joke at me or think I'm totally nuts at this, but go to Ancestry.com. I mean, seriously, just try it out and see what's there in terms of doing it. This was generated really, just so you know, generated in Utah by people who are, have large, nice families and I love the Mormons, and I have many friends in Utah that do this, but it was generated with that group. And it actually, I'm not saying it's perfect, but it actually offers you some interesting options of doing it. It's dynamic. You can actually, as a family, be able to put in this information. You can sign up for a free account for a month if you want to play with it, and you can see if your great-great-great-great-great-great-grandfather was John Smith. So you can do that type of thing. So that's one sort of, at least you'll get a feel for options that are out there. Health Heritage is actually one of the newer products that I'm not selling anything. I don't have stock in anything. Health Heritage is actually one of these interesting new options that some of you may have looked into. Or again, if you haven't, I encourage you to look at it. They're based out of Chicago. And the idea behind that is, again, this idea that family can aggregate, put together, and be able to input information about anyone's family information within the family. And they really are going towards being able to risk stratify individuals so that, for instance, if someone does have a history of colon cancer, be able to think about who's an appropriate person either for genetic testing or screening or anything else. And you can go online. There's a nice video that gives an example for a family, for instance, who goes through the process and can see that. This is very simplistic, but for any of you, especially that are clinicians, there's a very inexpensive app that you can buy for your iPad or your iPhone called Probands, generated by some of my friends who are at Children's Hospital Philadelphia. I admit that it takes a little while to get used to it, but it's relatively intuitive. It's a nice way of being in the office, having a tablet, and being able to essentially draw with your finger out a pedigree. Unfortunately, it still is very clunky in terms of importing what you get from that into an EHR, and in terms of being able to risk stratify or anything like that, doing any sort of risk assessment on the back end. I don't think there's any way of doing that. But if you like having a nice, beautifully drawn out pedigree, for those of you, I mean, sorry about that. I think it's like $5 for the app, so it's very inexpensive if you want to try it out. And the final thing I've shown is just one example, and this is out of MGH. The Hughes lab, or the Hughes group, has come together with a risk calculator, which is just one example. But for our breast group, for instance, knows about being able to do risk stratification for breast cancer. And this is a very nice way of being able to go in and take in several different both family history factors, as well as, if you will, environmental or epidemiological factors to come up with a risk stratification for breast cancer. And again, these things might be helpful if you were trying to think about, as, for instance, Kathy Crew is doing, how do you actually get to the masses? So how do you get to both the people who are the worried well, but they're worried that they have some risk. They think their risk is here, and their risk is actually down here. How do you help educate them better about this process? As well, just on the exact opposite. What do you do with people that they're not making the connection that they're actually at high risk? And once you start feeding some of this information and telling them about their risk, thought they were here, really they're much higher here, and some measures to be able to intervene. So if you get anything from today, what you should be getting is this is a very important problem for us as a healthcare system. And the thing that's remarkable about it to me is this is absolutely the foundational work in terms of any genetics or genomics. If we were to make one great stride that's not technologically all that advanced or all that expensive, it would be actually solving this problem. And what's just remarkable to me, truly remarkable, is that no one has done this yet. So if anyone decides they want a product they want to launch, this is absolutely something that across all the healthcare is something that we need to be able to have. Okay, let me stop here and just see any questions or comments about this part of it. Okay, so hopefully someone comes back to me with an answer before the end of this course. Okay, so why do we worry about this? So there are lots of diseases that we know that there's some sort of familial or hereditary basis for, and they're very common diseases, right? So these are not the esoteric things that I sometimes work with, but things like myocardial infarction, breast cancer, prostate cancer, type 2 diabetes. And we know that, for instance, even if you have just one first-degree relative with those diseases, that your odds ratio or relative risk for those diseases oftentimes goes up by twofold. Not necessarily tenfold, but twofold, simply by knowing that you have a family history. The earlier the age of onset for your family member that has those conditions, the higher the relative risk or the odds ratio is associated with that. Importantly, for many of these conditions, and I'll show you why this is important in the next slide, though, it's not just about risk stratification based on your family history or based on personally what's going on with you. We can actually do better than that. We can actually, in some cases, have genetic tests will help refine exactly what that level of risk is. But right now, these genetic tests right now are not inexpensive. And so to decide who actually needs this is an important thing. So for instance, I'll tell you, because I'm in breast cancer clinic all the time, we have a lot of worried well women who come into us who have one family member with breast cancer, and they're totally freaked out about their risk of breast cancer. But when we do the risk, we take the family history, we do the risk stratification, we realize that their absolute risk of breast cancer over a lifetime may still only be something like 16%, even though the population risk is about 12%. So it's a very marginally increased risk. And the question becomes, do I spend $3,000 on a genetic test for breast cancer for that woman, given that those resources, those healthcare dollars, might be better utilized either for her for some other purpose or potentially for another patient for, who really does need that type of testing. So when we think about breast cancer, and I'm going to focus on breast cancer because it's our most mature sort of disease and testing that we've got available for this. This is what the risk looks like, for instance, in the general population. This is the absolute lifetime risk, and then this is the relative frequency. And in blue are people in the general population. So you can see that, again, for women, on average, if you took the population average, we have about a 12% chance, all of us in this room, of developing breast cancer at some point in our lives. On the other hand, within this general population, what you can see is that there are a few women who are actually at really, really high risk, 30, 40, 50%, but it's a very small and very long tail. Most individuals are actually at this very low risk, less than 10% lifetime risk. If I take family history now, and I take not the group who's in the general population, but I take individuals with a family history, that's what you're seeing in that red dotted line. So those individuals actually have a higher risk on average than the general population. And you can see certainly I have more of those women who are in the very high risk group in terms of having the family history, but yet it's not heterogeneous. I mean, it's not as if everyone is in the high risk group. Even within the people who have the family history, I still have a lot of people, actually this big hump over here, who actually have a 10% or less chance of developing breast cancer. So even within the ones who have a family history, I still have quite a bit of heterogeneity. And so the question again becomes with the precision medicine, how do I differentiate these, whether they're in the general population or in the family history, how do I differentiate those who are in the really high risk from the population risk as we're doing this? So here comes the different factors that we use. So as we're doing this and as we try and risk stratify individuals, we'll take all the aggregate of all the information we can. These are different epidemiological factors, and I'm sure it doesn't project very well, but you can look at all the factors that we use. So we'll often ask people, for instance, when did they start having their period? How many full-term births did they have? Did they breastfeed? How much do they drink? How much do they smoke? We'll ask them all of these different factors. And I'm really sorry this didn't project, but all of these risk factors are on the order of magnitude of a relative risk of about 1.2 or 1.2, 1.4, but it's a relatively marginal increased risk. When, for instance, in comparison, you're talking about something like a BRCA1 or a BRCA2 mutation. So those are genes for hereditary breast ovarian cancer, and that relative risk is now running something like 8 to 10, depending on the exact mutation, depending on the exact gene. So within those families, so again, think about it back what we were talking about here. If you now take families that have a first-degree relative breast cancer, what you really have within that are different women with different genetic bases to that, right? So you're going to have some women who are Angelina, and Angelina Jolie with BRCA1 mutation, her risk is going to be right about here. So you take that, and with that genetic testing, you can now refine her risk stratification in terms of knowing more precisely what her risk is. And when we really want to get into this, we actually break it down by decile in age. So we can figure out what's your risk going to be in the 30s, what's your risk going to be in the 40s. And of course, ultimately, in terms of precision medicine, what we're trying to do is even use things like imaging or biomarkers to figure out, for instance, have you started developing little DIS, sort of a precancerous stage, and if you're doing that, is that sort of our early warning sign, if you will, that breast cancer might be coming, and in her case, do you do something like a prophylactic mastectomy? So within this, there's definitely utility beyond just the family history, because within family histories, on average, if you're talking about dominant conditions, you're going to have 50% of the family members that are at very high risk for that condition, but you're also going to have 50% of the family members who are actually at population, if not lower risk for those conditions. And so it's very helpful to be able to differentiate between those two segments, even within a family. And so hence, the next stage of this becomes not just using family history. Family history at this point, when we can't afford to sequence everyone's genome for every single gene, family history becomes useful in terms of figuring out which segments of the population we test for, we pay attention to in terms of different genes as we're going through. Okay, so that was the fun part. That was sort of the, let's think in the big picture. Now comes the very mundane part that I'm going to go through very quickly, but I want you guys, as you're going through this course, to make sure we're all speaking the same language. So I'm going to go through and just define a bunch of terms for you, because I want you all to be genomicists by the time you finish this. Okay, so when we speak about genotype, what we're talking about is essentially what is your genetic predisposition, or what is your actual gene, or what is your genetic variant at any particular locus. And when we talk about phenotype, we're talking about some sort of outward clinical manifestation of whatever it might be. So your phenotype could be breast cancer, your phenotype could be Alzheimer's disease, but that's what we're talking about. When we talk about penetrance, the idea of penetrance is what's the probability that you'll in fact manifest some of that, at least by a certain age, given that you have the genetic predisposition. With certain conditions, Huntington's disease, for instance, if you take someone to the age of 90, if they have an appropriately expanded allele, there's going to be virtually 100% penetrance for those individuals. For something like I mentioned, like a BRCA1 mutation, that penetrance might be 70% by age 70 to have some type of cancer. But what I mean by that is that it's only 70%. It's not 100%. It's not complete. It's not a done deal. For some conditions that affect children or some monogenic conditions that are relatively severe, like sickle cell disease, it's basically 100%. And it's 100% by very early on. But depending on the disease, depending on the exact gene and how hard you hit that gene, it can be anywhere from very low to much higher. And I have to tell you, one of the very interesting things about thinking and getting inside people's heads about this is exactly how they deal with it differently depending on that level of penetrance. That is the question of uncertainty and whether or not it's an absolute certainty that you're going to develop something versus being relatively low, sort of what that does to people's minds in terms of how they deal with that information and how they interpret 50%. So for instance, for many of you, if I were to tell you that you had a 50% chance of developing colon cancer by the time you were 60, would you think of that as a high risk or a low risk? Would you think it is more likely or not that you're going to develop colon cancer? And the interesting thing to me is when we ask patients some things like that, in fact, it depends. Their interpretation and their sort of the way they come to life as being either half full or half empty very much influences how they interpret those risks and those numbers, as well as whether or not they think they can do anything about it, which makes sense. So within this, as we think about this reduced penetrance or the idea of reduced penetrance, one of the most important factors is that it's not all genetically determined, or at least not all determined by the single gene we read out. Sometimes there are things in terms of exposures that you have, especially over your life course. Increasingly, we worry much, much more about either prenatal or early childhood exposures and what that ultimately does to risk, even for things like cancers and diabetes and metabolic diseases. And in fact, in some cases, there are also gender differences, which probably shouldn't surprise you as we think about this. In addition to that, and this is another sort of just vocabulary term, is this idea of expressivity. So that for anyone who has a particular disease, if you will, or genetically determined trait, it may manifest slightly differently in different individuals. And so I've just shown this example that happens to be for Marfan syndrome. Some people will present mainly with ophthalmologic findings. They'll have problems with dislocated lens or dislocated or retinal degeneration or retinal detachment, I mean. Some individuals, if any of you want to do this to yourself, will have joint problems. And so what I'm showing here is what we call a wrist sign. So you can take your pinky and your thumb and wrap them around your wrist and see whether or not they overlap, or a thumb sign and see how hyperflexible you are by seeing whether or not your thumb sticks out when you overlap your fingers and wrap them around your thumb. Other individuals will end up with aortic root dilatation, an aortic aneurysm, and die suddenly from that. So anyway, within all of this, you can have various different manifestations, but it's still inherently the same disease. But importantly, even within a family with the exact same mutation, and even potentially with the exact same environmental exposures, you may have different manifestations of different severity within different family members. And so it becomes tricky in terms of, as much as we'd like to be precise in medicine, in fact being just exactly that precise. The other thing that confuses us when we think about diseases, even genetically based diseases, is the actual mutation that a person has may make a difference. So that there are different alleles or different genetic changes within that gene. Some of those changes are really hard, really sort of beating that gene to death and destroy that gene completely. And in general, the disease manifestations in those particular cases will be much, much worse. For those of you who know the molecular jargon, these are things like loss of function mutations, premature terminations, splice site mutations, frameshift mutations, what we generally called or likely deleterious mutations. On the other hand, there are many other changes that are much more subtle, what we'll call missense variations or single amino acid substitution within those genes. And those particular variants may be much, much milder. And in fact, so mild that an individual may not be recognized as clinically having that condition because that penetrance may be reduced or they just may not think of it as a disease. It may just be for them a normal variation. In addition to that, there can be not just differences by clinical phenotype by the particular variation at one gene, but in fact there may be many, many different genes that can cause the exact same disease clinically. So examples, an easy one that I just talked about was BRCA1 in terms of breast cancer. There happened to be a number 2 gene that came thereafter, BRCA2, and both of those are associated with hereditary breast ovarian cancer. And to be honest, most of you couldn't tell the difference from looking at a patient or looking at a pedigree until we did the molecular genetics. And so we'll often call those phenocopies or looking the same, although there might be different genes that are involved. Finally, something that I find incredibly interesting, although most of you will think it's just geekish, is that in some cases we'll actually have one gene that maps to several different diseases. Very, very, very different diseases, in fact. And one of my very favorite genes of all time is the MNAC. It causes everything from a condition called progeria. So I'll have kids that are 8 years old, but they look like they're 80 years old because they have a premature aging process, to other patients with mutations, different mutations, but the same gene, who will have a muscular dystrophy or a cardiomyopathy. Other patients, again, same exact gene, but they'll have lipodystrophy. So they'll be one of these individuals where they literally have not a piece of fat on their body, just look like a Incredible Hulk. And again, I won't get into it today, but very, very interesting that it's the same gene that's involved, but different mutations leading to very, very different manifestations. And then finally, and I'll give you a personal example from this, one of the things we clearly are now starting to realize is that there are certainly some genes that have very, very broad effects in terms of the entire body. They will have pleiotropic effects on different parts of the body, such that there may be multiple organs that are affected within this. The one example I'll give you, which is very much a work in progress with our research right now, is that many of you may have seen that, for instance, many new genes have been identified in autism. And so we now, I won't go into that, that's a different TED Talk if you want to watch it, but we now realize that there are many, many different genes that are involved in autism. I happen to have another study that looks at congenital heart disease, and when we were looking to identify the genes for congenital heart disease, we suddenly realized that the same exact genes our right hand was looking at to identify for autism were the same genes that we were identifying in our studies with congenital heart disease. Now, it was like both of us looking at the elephant, but one person looking at the trunk and one person looking at the tail. When we went back to the autism studies and looked at those individuals and looked at things besides their neurocognitive phenotype and started looking at their medical history and looking at their hearts, we realized that many of them had congenital heart disease, but simply those studies weren't focused on that. When we went to the children who were in the congenital heart disease study, what we realized is that many of the cardiologists had thought that the reason that they were learning disabled or having problems in school was simply because they had a long bypass time with their open heart surgery, or maybe they had a Rocky PICU course or something else. Now that we realize that it's the same genes, in fact, their brain was essentially developmentally affected by the same process, but no one who would have known at the beginning. They didn't necessarily look syndromic or dysmorphic, but again, one of these things where, as we see the convergence, one gene having effects on multiple parts of the body. And at least in pediatrics, this is something that we're quite used to in terms of seeing. Okay. So I'm going to go relatively quickly through this because one of the challenges is when you think about how to do something like machine learning or how to do this recognition from family histories is how to think about not just the rules but the exceptions. And a lot of the exceptions are what get us tripped up. I will say, just to totally put myself out of business, this will become increasingly less important as we figure out how to interpret a genome. So this right now, this is actually critically important because I have to look at a family history, I have to look at a patient, and I have to guess the diagnosis so that I order the right test. In 5 years, you're not going to need me to guess the diagnosis. All of these wonderful diagnostic skills I've acquired over the last 20 years, all you're going to do is need me to read out the genome, and I will tell you what the phenotype is when I never even saw the patient or saw the family history. But for the next 5 years, I've got a job as a clinician. Okay, so what do we do within these things like the Proband app? They actually draw all of these nice, beautiful symbols. I'm not going to get into this in any detail, except to say that we generate something that looks kind of like this. So the genetic counselors know exactly what this looks like. For something that's autosomal dominant, if it behaved itself perfectly, you've got 2 copies of all your genes, except on the X chromosome. With a dominant condition, you've got one that's completely normal. You've got one that's got some sort of mistake or typo. When you have your kids, it's a 50-50 chance of passing them down. And if it behaves perfectly, that means on average 50% each generation for someone who has the disease has a child with the condition. So that's what we see with autosomal dominant conditions in general. It's the type of thing where we can see males and females both being affected by this condition, and it behaves itself nicely. However, it doesn't always behave itself nicely. And so here are some of the exceptions that we see. So we can have these issues with reduced penetrance or age-related penetrance. We can have this idea of variable expressivity, so different people have different manifestations, and people don't necessarily get clinically recognized or identified as having the same condition within the family. And an important thing, and for those of you who are pediatricians, I want to highlight this portion of it. One of the things that increasingly we realize that's very, very important is that for very bad pediatric conditions, things especially that you die from before you live to have children, a lot of the disease burden from a genetic point of view is due to de novo or new mutations when you only have to mutate one copy of that gene. So it effectively would act as an autosomal dominant condition, but in fact, most of those kids don't live long enough to then have children of their own and be passed down. And so in fact, what we see from a population point of view is that those mutations essentially get snuffed out each generation because those kids die and they don't live to pass them on. And the only way we see them in a population is because they arise new each time. The other thing that's fascinating, and Chris Walsh has a nice paper in the New England Journal of Medicine for this about brain malformations, but we know it's true of other birth defects as well, is that all of these mutations are not necessarily germline mutations, but in fact the very worst of those mutations are what we call somatic mutations, which will arise after the point of the egg and the sperm coming together, and there will be mutations that arise as the embryo or as the fetus is developing. And the reason I say that those are the very worst of the mutations is that because those mutations are in fact so severe that if you had them in every single cell in your body, you wouldn't be viable and live to actually be a born child. And so what we see are the only individuals that survive, the only fetuses that survive with those conditions actually end up being mosaics or having only a subset of those cells within their body that are affected with that. It's, for those of you that are interested, it's another discussion, but just to realize within this, what you'll oftentimes see is what I'll show you later, that you get no family history of the condition whatsoever, yet it's a very strongly genetic factor. When we see those things happening for those very severe mutations, this is a family that I took care of with osteogenesis imperfecta or brittle bone disease. One of the things you can sometimes see is that in this particular case, one father who had children with 2 different wives ended up both with an affected child from both of his wives for this autosomal dominant condition, and that's because he is actually what we call a germline mosaic. So in fact, he doesn't have that mutation in the cells of his body and his bones, but he has them in his gonads, he has them in his testes, so he can actually have not just one, but potentially 2 children with this condition. And so the reason I put this in is these exceptions are what sort of confound us as we're trying to use these automated tools. And this is just to show you visually that what happens with the idea of mosaicism is you start with your cell with this, or you start the body with a single cell, but somewhere down the process as you go division after division after division, there's a mutation that arises somewhere here and then affects that single part of the body that's a daughter descendant cell from that. Okay, so within this, there are a lot of conditions that are dominantly inherited. In fact, most of the ones we recognize, I would say, are either at the extreme of being very, very severe pediatric disorders, or tend to be the other extreme, which are, sort of well into adulthood, usually into the 40s or 50s when these things happen. And for those of you that have interest in these, we see it everything from cardiac diseases to neurological diseases to metabolic diseases. It's really across all different clinical areas that we see these types of conditions. Within this, as we see this is a case of neurofibromatosis. We can see these de novo mutations, and the point that I'm making here is although this individual had the de novo mutation. Once an individual does have that mutation, it becomes a 50-50 risk of passing it on. So it looks like it came up out of the blue, but then once it came up out of the blue, it gets passed on to generation to generation. And the family that I had yesterday with this condition was a gentleman with Lee-Fraumeni syndrome. His mother died at the age of 41 of breast cancer, but there was absolutely no antecedent history of any cancer within the family, and that was because his mom was the new mutation, but then when she passed the mutation to him, he ended up being the lucky person to have 3 different independent primary cancers as the result of the Lee-Fraumeni syndrome. So we can see that type of things within families, and it can look like it comes out of the blue. Let me just quickly go on from here. There's some very interesting conditions for a few of you that study things like, in this particular case, those of you who are endocrinologists, that have gender-specific expression. And so this is a case of precocious puberty, and you can imagine how those things happen. But I'll also tell you that one of the diseases I work on, which is interesting, is pulmonary hypertension. Some of you guys know that. What's interesting to me is that in the same family with the BMPR2 mutation for pulmonary hypertension, about 40% of the women with the mutation will get pulmonary hypertension, but of the men, it's actually only about 15%. So exactly why we have that sexual dimorphism is one of the things we're trying to figure out. But even in those clear autosomal sort of simplistic cases, there can be differences like that. Okay. Autosomal recessive conditions, it takes 2 to tango, so you've got to have mutations in both copies of those genes. Thankfully, these conditions are less frequent in general, but there are many more. We know of many more conditions. The interesting thing to think about this is when you have 2 parents who are both carriers for these conditions, there's a 25% chance of all of their children inheriting these conditions. And one of the points I want to make in terms of this is because many of these, again, are relatively severe conditions that women thinking, or I should say couples thinking about having children or family planning, start using this type of information to try and decide could they both be carriers for the same condition, because otherwise you don't usually see this in a family history. The usual family history you'll get is that you won't realize it's in your family until you've had one child that's affected with this, and many of these conditions are pretty severe. So one of the, if you will, big clinical tests, high-volume clinical tests that people are going through right now is actually carrier screening. So I don't know how many of you have had kids in the last 10 years or so, but you can imagine, or you don't even have to imagine, this has started out in different populations for different diseases. So for instance, within individuals of Ashkenazi Jewish descent, many times this started out as Tay-Sachs disease, because Tay-Sachs is a pretty devastating condition that 25% of the kids of carriers would be affected. Right now, the, if you will, Jewish panel, I think we're upwards of 22 different conditions that are on that panel. In the same way for other individuals, cystic fibrosis is a major thing that started with this. But the idea that's sort of run very interestingly, sort of gone large scale, is the idea that if you're screening for one condition, why stop with one condition? Why not just scale that? As long as you're in the doctor's office getting your blood drawn, sending it out to a test, why just stop with cystic fibrosis? And so does anyone want to guess, in the carrier panels that are now being offered to many women, how many conditions or how many mutations would you guess that they might test for? Cystic fibrosis is one. Take a wild stab at it. 15 or 50? 50, okay, 50. I've got a bid for 50. Do I hear more? Come on. So the current panels that are being offered are actually 100 plus at this point, over 600 mutations for 100 plus different genes. And this number is increasing quickly. Kelly and I think, are always befuddled at exactly how quickly it's increasing. But as we're understanding the underlying different diseases and how common those mutations are, they're developed with great rapidity. I was just actually in the Middle East a couple weeks ago, and you can imagine, appropriately so, the conditions based on the population architecture in, for instance, Saudi Arabia would be very different than they are in Harlem, right? And so what we're starting to do is develop these population-specific panels in terms of reproductive options that are regionally specific based on where individuals are in terms of their genetic ancestry. The biggest challenge we have in New York is that everyone's from everywhere. And so as we do that, we have to come up with sort of omnibus solutions to being able to do all of this. As I mentioned, we've got conditions like cystic fibrosis, sickle cell disease. The interesting one, though, and no one has to vote on this, but I'm just going to ask you for show of hands. One of the ones that we struggled with when we decided about these carrier panels was what to do about deafness. Is deafness actually a disease, or is it another language that people use? Is it a handicap, or is it just a variation of normal? And so you don't have to vote, but I'm just curious if you do want to vote. If you were planning on having children and you knew that you could screen for this and be able to, in an ethically appropriate way, you wouldn't necessarily have to have an abortion to do this, but if you could know that you might have a child who was born with congenital deafness, or not, you could avoid it with that, how many people would want to have some sort of test to figure out, if they and their partner were going to risk for this? And how many people would say, not a big deal, it's just a different language, just a way. Okay, so interesting. So obviously there are differences of opinion here, and that's why people get to vote with their feet and decide for themselves whether or not they want to do this. I have to admit, it took me a long time to figure out, and it was largely due to things just like we did, which was essentially listening to people and what they would want, that we did actually finally include deafness within these panels because we decided people should have the option of deciding. They could find out this information, and for those of you who haven't figured out, I'm very much pro-choice, and so pro-choice means for me that patients get to choose. So that actually is now part of the carrier screening panel of things that we do. So within this, I'm just going to go on quickly. Those are recessive conditions. X-linked conditions are obviously ones that are on the X chromosome. Males more generally affected than females. The most common is the one that actually I have, which is red-green color blindness. I'm not colorblind, but both of my sons are. And that's due to a mutation that I carry on the X chromosome. So as we're doing this, I won't go into too much detail on this, but this is something that you can easily be able to figure out based on the transmission within the family and knowing certain things like hemophilia, Duchenne's muscular dystrophy, OTC deficiency, a variety of disorders can be X-linked. As I said, there are some common traits that actually you can get females that are affected for, and the most common of those is red-green color blindness. Anyone here red-green colorblind? Yeah! Okay. So anyway, so we as geneticists, we screwed ourselves in this because if you look at our electropherograms, we use actually red and green. So we weren't actually thinking of ourselves as we did this. As we do this, the thing that gets complicated about this is this process of lionization or inactivation of genes that are on the X chromosome. So the biggest problem we have in females is that females usually are asymptomatic from these conditions, but every once in a while we get a zinger of a woman that got unlucky with her lionization and actually has problems with this. And so we can have the most common condition we screen for now that's X-linked is called Fragile X. So it's actually the most common cause of intellectual disabilities in children, accounts for about 1% of that. And prenatally, our custom now is to actually offer all women the option of screening for Fragile X at the same time we do things like cystic fibrosis. And interesting, for those of you who are on the ethical side, an interesting thing, though, because Fragile X, when you have a full repeat, causes Fragile X. But on the other hand, there's, for a smaller repeat size, causes a condition called ataxia tremor syndrome. And for women who have, again, can have the manifestations of this, one of the manifestations they can have is premature ovarian failure. And so just some of the challenges that we have when we're trying to counsel women about this, again, is this idea of having multiple effects from a single gene. It makes it an interesting conversation when you come up with these things, not just that you're potentially having reproductive issues, but issues actually for that woman or for other family members in terms of having a neurological condition later on in life, or potentially having things where they may have trouble conceiving, which we see with fair frequency. Okay, so we can see those types of conditions. I won't go too much into this, but to say that one of the conditions, which, and I throw this out there just for those of you who are genomicists and really like clever things, for almost all conditions, women are less affected than male, with this one, not just this one, but a classic exception of craniofrontal dysplasia, in which actually females are more severely affected than males, because in this particular case, the two different subunits of the enzyme or of the protein actually don't work well together. So if you have one mutation with one normal allele, you actually end up with a worse phenotype than if you just have a mutant allele. So anyway, that's just for those of you who like playing genetics trivia or genetics Jeopardy within this. One of the other things you can see, this is actually a case of incontinentia pigmenti, and these sort of zebra stripes that you see. I don't know how well this is projecting, but you can actually see the patterns of X inactivation or lionization on the skin. So for this condition of incontinentia pigmenti, these hyperpigmented spots here are where she actually has the mutation within that gene that's been active. And so you can actually see within the surface what you're seeing essentially throughout her body. And in this particular case, this condition is so severe for a male that the males don't survive. It's one of the things that we call an X-linked lethal. And then finally, what can be confusing are what we call mitochondrial disorders. So remember that most of your genes are within the nucleus and encoded within the nucleus, but you've got a few that are in the mitochondria that get passed down maternally. And so within those, we can see oftentimes very, very different manifestations in different members of the family. And this has to do with this concept of heteroplasmy. So this idea that this is now population genetics at the cell level. I apologize, this doesn't project very well, but these are all the different mitochondria. The ones in green are meant to be the mutant mitochondria, and just by luck of cell division, you may end up, as that cell is dividing in the developing embryo, with certain cells and certain tissues that have a very high proportion or very high burden of the bad mitochondria, and other cells that have a very low burden of the bad mitochondria. And so within a single family, just by chance alone, you could have someone who might have, for instance, a very severe neurological manifestation. Another person, their brain might be totally spared, but might have very severe heart disease. And so these are actually some of the most difficult conditions for clinicians to diagnose because they have such different manifestations even within the same family. And so that's sort of the easy ones, and then in reality what we see most of the time are these things that befuddle us, which are multifactorial, polygenic, you know, whatever you want to call it, but it's essentially what is most of medicine, 90% of what we do. And at this point, this is the holy grail in terms of putting together multiple different factors to try and predict risk. And you've heard about that from Dr. Ottman as well as Dr. Leibel. So now I'm going to let you test your skills. So this is active learning, like we like to encourage. So this is your family history. I'll just let you know this number 3 in the middle here is a shortcut just to say that this represents 3 different males. This represents 2 different females. We just got kind of lazy in doing that. The people who are colored in dark in this particular case have the disease, and the people who have lines drawn through them are deceased at this point. So if you had to guess for this family, what would you guess is the mode of inheritance? And I ask myself questions when I look at these about saying, well, do I have males and females who are equally affected? Do I see that it's generation after generation? Do I see that it's always passed through the maternal line of things? Do I see that it skips generations? Do I ever see male-to-male transmission? Just sort of little tricks that I use to try and figure out for myself what I might be worried about in terms of mode of inheritance, because if I know mode of inheritance, oftentimes I'll know a subset of genes that might be involved in that case. So anyone want to take a guess? Autosomal dominance. Okay, so autosomal dominance is starting to look good. We see males and females equally affected. That makes sense. I see transmission, basically 3 out of 4 in the first generation who are affected. That's not bad. It's pretty close to 50-50. But then the problem is I get to this generation here, and something's a little off. I've got an affected woman here, and I've only got 1 out of 4 of her children affected. I've got an affected male here, and I've got none of his 8 children affected, and this affected woman here, and none of her 2 children are affected. So how can that be autosomal dominant? I'm not saying you're wrong. Okay, so it could be incomplete penetrance or even more on the incomplete penetrance. Someone I know is right there, probably one of the geneticists in the group. But age-related penetrance, absolutely. So when you think about this generation, if this is like our generation here, for most of us, our grandparents are deceased at this point. And in this generation, our parents may or may not be alive. If this is a condition that might be, for instance, colon cancer, Alzheimer's disease, myocardial infarction, it wouldn't be surprising that generation of our generation might just starting to be affected by this condition, and people like our children are just too young to develop Alzheimer's. And so when you think about this, this is oftentimes the type of pedigree that we get. And once we give you some hints in terms of the shading stands for colon cancer or the shading stands for Alzheimer's, it makes more sense. But just in terms of thinking about this, the point I'm making is that if you were to think about an algorithm for figuring these things out, it's actually a little bit more complex than just pattern recognition. You've got to actually build in some thought behind this, which we can do, but it's not trivial. Okay, the last one I'm going to ask you for today, and then I'll let you guys go. But what's the mode of inheritance for this one? Everyone's looking and scratching their heads, and I'll tell you that this is the most common family history that I get coming into my clinic, okay? So the reason why this is because in many cases it looks like you've got absolutely no family history. And the parents come in, oftentimes it's parents of a child, and they'll come in and they'll say, Dr. Chung, you're a very nice woman, but I have no idea why I'm here because I have a clean family history. I have clean genes in my family. We have nothing genetically wrong with us. And so instead, when you start thinking about this, of all the different possibilities, it could be autosomal recessive, right? So it could be that this is just the first time two carriers have married into the family. It could be X-linked by a similar mechanism. It could be dominant with a de novo mutation, as someone was saying. That's what we see with fair frequency, as I explained to you. It could be a mitochondrial disorder. I haven't even bothered to stretch your mind on this, but it could be an imprinted disorder. So the bottom line is it can be any of the above, and that your family history gives you no information. And I've just spent the last hour telling you about how important it was. But in this particular case, we actually get no information from this, yet this is actually a very common genetic thing that we will see. These families are still families that have a genetic factor. Whether or not it's hereditary is very important for those parents to know, because that'll determine whether or not that risk of recurrence is something like 25% or something closer to 0 as we're doing it. So my point being from this little exercise is that the family history can actually be very informative, but it doesn't always tell you the answer that something is or isn't genetic as you're doing this. I'm going to throw out one last question, just again, because I wanted a little something for everything. For those of you who think about these ELSI issues, in fact, this is the most common type of family history I now get when lawyers come to me. And the reason lawyers come to me is because they have started coming and asking the question, you have a child with bad outcome, happens with fair frequency, and someone is trying to cast blame. They're trying to say, whose fault was it? Little Johnny is autistic, has cerebral palsy, or has some sort of birth defect. And the question becomes, is it the genes? Can you blame it on the genes, and can you blame it on Johnny? Or can you blame it on something, for instance, that the obstetrician did during the delivery? Can you blame it on an exposure that the mother was, exposed to during her job? Can you explain it on the asbestos? Whatever it is, but someone's always got someone they want to blame on this. So from a very interesting point of view, you get a family history like this very oftentimes, and you can't say that it is or isn't genetic just by looking at the family history. And we'll see how the legal system continues to go on this. But with fair frequency, now the answer is, well, you just need to sequence their genome. You've got to be able to look at all of their genes and figure out whether it's genetic, because obviously in terms of assigning blame for this, it's one thing if it's in the genes, it's quite another thing if it's the obstetrician who had some problems with the delivery.